Dr. Brandon,
Hello, Dr. Morgentaler.
have I told you how much I like those red glasses on you?
You have, actually. But thank you again.
They're great. So I got excited today, and I just wanted to share with you a topic that sounds crazy, which I've left alone for a long time, but it's about testosterone use in men with metastatic prostate cancer.
Before we start, a small disclaimer. The Sex Doctors podcast is not a substitute for medical or psychological advice.
So testosterone supplementation.
Well, I don't use the word supplementation, but testosterone use.
Okay.
Yeah, and in guys with metastatic prostate cancer. And the reason why it's cray-cray, or allegedly cray-cray, is because the standard treatment for men with metastatic prostate cancer is reducing their testosterone as low as possible.
Right.
We call it androgen deprivation.
Yep.
Came about because of this guy, Charles Huggins, from his work in 1941, so 80 plus years ago. And he showed that if you take men with metastatic cancer, which is how most men in the 1940s were diagnosed, the cancer had spread, they didn't have PSA, they had no way to find it early. And he showed that if you remove the testicles, which is the source of testosterone, that a blood test marker at the time was called acid phosphatase, got better, became lower. It was high in some cases when it was metastatic. They removed the testicles, came down, and that was standard treatment, believe it or not, removing the testicles until the 1980s. I was in training right around the time it changed. We still lowered testosterone, but some new medications became available. The best known is called Lupron, but there are others. And they lowered testosterone, and guys, that became standard therapy. Now, in the early days, it was never shown to actually improve lifespan. But if people had pain from spread of the cancer to bones, the pain got better. If they had masses from the cancer that maybe blocked something like a ureter, the passageway from the kidney to the bladder, so those masses would shrink.
Wow.
So removing testosterone clearly helped in the short term, at least, but eventually the cancers would come back. And it was never shown to actually improve survival, although most people thought it probably did, but never shown. Then probably now, we're talking 15 plus years ago, were some new agents, medical agents, that lower testosterone even more. And those have been shown to improve survival, slow down the progression of cancer. And so, during all this period, we've thought of testosterone as like gasoline for a fire, right? Now, the data have been really clear that giving testosterone to men who don't have prostate cancer is fine. And we have, a fair number of randomized controlled trials, meta-analyses, which are, looking at multiple randomized controlled trials. We show nothing. The most important is the Traverse trial, was published in 2023, the largest randomized controlled trial ever of testosterone. And it was over 5,000 men, 33 months on average of follow-up. And the number of cancers in the testosterone group was 12, and in the placebo group, 11. It's the same.
Yeah.
So you and I have spoken here on the podcast, and I've written extensively that raising testosterone doesn't seem to be a problem. One of the things that happened to me in the course of my career as I was treating patients, people would read my articles and they would come see me from around the country and sometimes internationally to say, I've got prostate cancer. I used to be on testosterone. Now nobody will prescribe it for me. Will you? I don't feel as good now that I'm off it. Or they had metastatic cancer and they'd gone through the standard treatment, which was to lower their testosterone, and they felt miserable, weak, fat, no sex drive, no vigor, no motivation, depressed. And some of these men asked me if I would treat them with testosterone. One man, 10 years ago, came to me, and I had treated one or two men prior to him with testosterone.
You mean who had
Who had metastatic cancer. And I lecture about this guy a lot. He's out there on YouTube, and he was 94. My first page was 94 years old, and he didn't shame me into giving him testosterone, but I was really reluctant, and I told him what the real teaching was, which was, I give you testosterone, you could die tomorrow,
right,
or in a week.
Yeah.
And his retort to me was, "Doctor, I'm 94 years old. I've got metastatic cancer," and his would spread everywhere. He says, "I'm going to die soon whether you treat me or not.
Yeah.
But while I'm alive, I want to live." And he wanted to feel more energy. He wanted to start exercising. It used to make him feel better. Anyway, I treated him, and he did great for a long time. So he, at 94, he was 95 when he eventually succumbed to his cancer, but he gave me the courage to treat younger men. And in 2021, I published a paper that included on guys with advanced prostate cancer, who I treated with testosterone. I didn't have an agenda. These are all individuals that came to me and said, "Please, would you treat me?" Almost all of them had heard about me or read my papers or something like that. And included 13 guys with metastatic prostate cancer. And not one of them had that rapid progression that I was taught would happen. And which, in retrospect, now that I've researched all the literature of this and made, written many articles, there's actually no evidence that giving testosterone to these men is dangerous. None. It's a little bit like an old wives' tale. Not a little bit. It is an old wives' tale. So the one exception being that men who had already been castrated or who had super low testosterone, like if they'd gotten benefits from lowering their testosterone and then we raised it again, not we, but if they'd had their testosterone raised, whatever benefits they had, like shrinkage of a mass, it was going to get reversed, right? But if you gave it to a regular kind of guy, not previously castrated or androgen deprived, there was evidence going back to the 1950s and 60s that not much happened to these guys. And now we know, so the Traverse trial I just mentioned, where there was 12 cancers in the testosterone group, 11 in placebo group. What most people don't, a lot of people know that study, but what most people don't appreciate is that 1 out of 7 of those men has pre-existing prostate cancer that you could find if they had a biopsy. But there's no reason to do a biopsy because their PSA is normal. And we know that from studies that I published in 1996 and in 2002 or something like that, in over 400 men. 1 out of 7 men with a normal PSA, low testosterone, has biopsy detectable cancer. And so if you look at the Traverse results, those cancers that are there, even though we haven't diagnosed them, but 1 out of 7 guys has them, those obviously didn't get much worse, or else they would have been picked up.
Right, for sure.
So the data is actually huge. And we have a paper submitted. We say we meaning my co-author is my dear friend and colleague Abdul Traish. We say the evidence is overwhelming, and I believe that's true. Overwhelming that testosterone does not, quote unquote, drive prostate cancer. So going back to this patient who I treated 10 years ago. So he came to see me, and I treated him, and he had metastatic disease to his bones, and he was told that standard treatment was to go on this medicine that would lower his testosterone. He and his wife said, we're kind of alternative people. We think testosterone and hormones in general are probably good for the body. And we think it's wrong to lower testosterone. As a matter of fact, if we'd actually like to see if you might, bump up the testosterone.
Oh, wow.
So I did that with him. And I published his results too. That's in a paper from 2020. He's one of a few patients. And his story was that I gave him testosterone continuously, just regular testosterone supplementation, and he did super. He felt better. He became sexual again because his levels had been low to start with. And nothing much happened to his cancer, except the PSA creeped up and up and up. And when it got to a level that was scary for him, which was about a year, he stopped it. He had an oncologist locally. He was from out of state. And he said, I'm just nervous about this. So we stopped. He came back a few months later. And this guy, Sam Denmead, who's this superb oncologist at Johns Hopkins, had written a groundbreaking paper where they had a protocol where they treated these guys with far advanced prostate cancer, where the cancer at the end with prostate cancer, it doesn't respond anymore to testosterone being lowered. So we call it castrate-resistant prostate cancer. And it's usually a bad prognostic sign. And he came up with this idea that of cycling quickly between very high levels of testosterone and very low levels. They had done some experiment in, I forget, mice or rats in a rodent model and showed some benefit. So they got high-dose testosterone, which has been shown separately as actually keeping testosterone keeping prostate cancer in check, at least in the test tube, with prostate cancer cell lines that are kind of these immortal cells that you can just keep doing stuff with. And so they used high dose, and the patients were also on a medicine like Lupron, so they weren't making any of their own testosterone. So they gave them an injection on day one. Testosterone went sky high. After the testosterone injection is used up, the body's not making any, it drops down to castrate levels. And they called it bipolar, because it goes way up and way down, bipolar androgen therapy, or BAT, and so we call it BAT, BAT. So my patient back then, 10 years ago, said, I saw that article. A very smart guy, he and his wife were on top of the literature. He says, could you do something like that with me? But he'd experienced the benefits of testosterone. He says, but maybe you can come up with a protocol where I'm on testosterone for longer periods than what they're doing at Hopkins. So I put him on a treatment that I ended up using in, 6, 8 patients, something like that, called modified BAT or MBAT, where I had men on high-dose testosterone. The high dose is a key component. They were on it for 8 weeks, roughly 2 months, and then they'd go on 4 weeks of a medicine that quenches the testosterone, that stops it, enzalutamide, and which is a standard medicine now for men with metastatic cancer. And so he did that, and we measured his PSAs and his testosterones as he was on the peaks of the testosterone at the end of the 8 weeks, and then at the end of the 4 weeks where he had the quenchers, and his PSA would go very high, and then it would drop down to nice levels, which was very reassuring. And he did that for 2 years.
Wow.
With if I remember right, hardly any progression in his disease.
Wow.
At the end of 2 years, he'd had a metastatic deposit in his hip. He said, my hip is bothering me more when I'm on the testosterone. I've been talking to my local oncologist. I think we'll stop with this. And we just went on the enzalutamide. And he did that on and off. So out of the blue, 8 years later, he contacts me. He's still alive. It's 10 years since we started with him.
Wow.
He now wanted my advice. He's now, he moved, seeing other doctors. And it's an amazing story. For men with metastatic cancer, their average lifespan is about 3 to 5 years once you're diagnosed with metastatic disease. Some people live longer. Some people live less long. The number of men who make it at 10 years is roughly 10%. Now, it's very possible that this gentleman I treated with testosterone might have survived 10 years if I'd never treated him with testosterone. But the odds are that he wouldn't, that he wouldn't make it this far. And the fear that testosterone fueled the cancer cannot be true in all cases. It wasn't true in his case.
No.
I've got a second guy who has been on testosterone high dose, but he's been on it continuously, not the cycling part, also for around 10 years, metastatic disease. I had a third guy who was on it for 7 years. He ended up dying, but not of prostate cancer.
Wow. Wow.
So, it's the world is just beginning. The urological and oncological community around prostate cancer is just beginning to understand that testosterone is not fuel for a fire. It is not. And we're starting, at least in the United States and in Canada, to give men testosterone if they've had prostate cancer that's been successfully treated. Surgery, radiation. That's not uncommon anymore, although in Europe, still very uncommon. And the results of that, by the way, have been, people have studied, no RCTs, no randomized controlled trials, but a number of observational trials where the guys who got testosterone did just as well in terms of their cancer.
Wow.
As men who never saw testosterone. And one of those studies out of UC Davis by Tom Allering and his co-investigators showed that if you went on testosterone, you had a lower risk of progression of your cancer.
Oh my goodness.
So this thing is changing, but the thing that is so hard now is I still get individuals contacting me, sometimes with their doctors. They've got metastatic prostate cancer.
Yeah.
And their testosterone is low, or they've made it low with standard treatment, and they're miserable. And they want to know, doctor, can I go on testosterone? And in the past, there was nobody that did this.
Yeah.
Now, to me, there's a handful of docs out there who, for quality of life, if they have a good relationship with the patient, are saying, I'm willing to treat you so, you feel better while you're alive. Usually the men say, I'm willing to have a shorter lifespan, but I'm not sure it shortens their lifespan by 1 day.
Wow.
And I think it's possible it may even be beneficial.
Like, is that too much to say? Like lengthen their lifespan?
I think I don't know the answer because I don't have a control group. But having now had at least 3 long-term survivors with metastatic prostate cancer, out of a group of not that many. We reported on 13, but some of them stopped within a year or two. 3 out of, I don't know, maybe there were 7 that, did it for more than a couple of years. Long-term survivors, that's pretty impressive.
That is impressive. So what are the studies that need to happen now?
Listen, I think this shouldn't be so crazy anymore.
Yeah.
There's a lot of benefits to it, right? In terms of quality of life, certainly.
Yeah.
Right? The fear that it makes cancer grow rapidly is clearly not true. It may not be as good. It's possible it may not be as good as not being on testosterone, or that androgen deprivation may be better. Possible. But for quality of life, it's clearly better. I think there should be a randomized controlled trial.
Yeah.
There have been a couple short ones, at least one, I think 2 short ones where they didn't last very long, but nothing terrible happened. So I think it's time. This thing, we've been stuck with this idea that came from a guy from 1941. Yes, he won the Nobel Prize. Part of what he said was true, right? Like the deprivation part does appear to be helpful, but the idea that
when you're treating the cancer.
But the idea that raising testosterone is bad, no, I think that's wrong.
Well, that's fascinating. It's awesome.
I'm excited. I think it's time. I'm not at a point in my career where I can start a randomized controlled trial. No, I can't. But if anybody wants to do it out there, I'm happy to consult with you and tell you my stories, and share with you some of my thoughts about this. But I think that there is science behind it, and I think that there is now limited but existing clinical data on this.
That's fabulous.
Yeah, and the potential benefits are huge.
Yeah.
Yeah.
Well, Dr. Morgentaler, thank you so much for your wisdom on this topic.
Dr. Brandon, as always, it's a pleasure to talk with you. And thus ends another episode of the Sex Doctors Podcast. You can find us at thesexdoctorspodcast.com. And Dr. Brandon, what should they do, so the listeners and viewers, so they don't miss any of our content?
Yes, please subscribe.
Subscribe.
And then, yes, you will be sure to get all of this.
You'll get notifications about every one of our exciting episodes.
Yeah.
Well, that does it for today. Bye-bye.